on the web, and in your hands. This is MDiTV.
Last November, an independent panel of experts caused a ruckus when it released a new set of recommendations that said many women under 50 might not really get much net benefit from annual mammograms. The results set off a blistering reaction, including calls for legislation to require insurance coverage for annual mammograms. What the U.S. Preventative Services Task Force said was that based on all the latest evidence, women under 50 who don't have any special risk factors for breast cancer should talk with their doctors about how often to get mammograms. That's because while mammograms can find some early tumors, the scans aren't as effective in younger women as they are in older women. And they also expose women to radiation, as well as follow-up exams, anxiety, and even surgery that may be unnecessary. So the task force said it's not a slam dunk that the potential benefits of mammography outweigh the potential harms for every woman under 50. The panel also confirmed that there's no reliable evidence that breast self-exams save lives. Who are these experts? The U.S. Preventive Services Task Force is a collection of private sector experts in prevention and primary care commissioned by a federal agency. They rely on research generated from a dozen evidence-based practice centers located throughout the country. The task force issues summaries of medical evidence. It's up to others to decide whether and how to use that evidence. But many people feared that the report might affect their health care insurance coverage. Dr. Heidi Nelson, the lead investigator of the mammography report, admits in retrospect that her group could have done a better job explaining what the report was talking about and who it applied to.
Screening involves a routine test for individuals with no symptoms, no complaints. It's a different thing, and I think there's confusion early on about what we're really talking about here. We're talking about screening, not all the other things, the workups we do when there's an issue, a change in breast findings.
She also notes that the task force's recommendation, which was based on her published study, was a guide for clinicians and patients and shouldn't be interpreted as a rule.
Right. Well, these are called recommendations, and the language around them is very friendly to clinicians to make judgment calls. Judgment always trumps a recommendation. And the task force and other professional groups are becoming more and more aware of the role of shared decision-making with patients.
Patients did, in fact, stand up and take notice. And that's a good thing for medicine, according to Nelson.
I think that the public is getting involved in discussions and probably learned a few new terms like overdiagnosis and false positives and things that patients need to know about to make good decisions for themselves. So we have lots of teachable moments here to get everybody on board and thinking along these lines, but it's never an absolute. Judgment and patient preferences have a huge role. So if we can kind of put that in perspective, it looks a little different. It isn't so threatening.
The furor over mammography recommendations is likely a taste of things to come because of growing interest in what's known as comparative effectiveness research. Currently, most medical research compares a new test or treatment against doing nothing, the so-called placebo-controlled type of trial. On the other hand, comparing alternative ways of dealing with a disease or risk can help researchers figure out which option produces the best results. A second step is to then include costs in the calculations. Advocates say that'll help us get the best health value for our healthcare spending, while critics worry about patients being denied coverage for tests or treatments they believe could help them. With money and lives on the line, we're going to have more of these brouhahas over healthcare recommendations. Here to give us a perspective of how one insurer is handling such recommendations, as well as the potential effects the comparative effectiveness research has on the business model, is Sue Hennessy, Vice President of Health Plan Services for Kaiser Permanente Northwest, and Dr. Tom Siltebo, Clinical Quality Representative for Kaiser Permanente Northwest. First off, Sue Hennessy, how do you use recommendations in developing what Kaiser Permanente is going to offer its customers?
Great question. Here at Kaiser, we have a long-standing practice and history of using evidence-based medicine and rely on the studies that come out of the prevention task forces and many other medical research efforts to guide us in what is the most appropriate level of care and what will drive toward the best outcomes. So the way that we would use a recommendation like this would be first to determine what the care should be and what the best care is, and then the benefit gets derived and aligned with trying to achieve that through the cost share or no cost share in the case of prevention.
Now, putting aside what you think of the specific recommendations regarding mammography and whether the science was properly communicated to the public, there was a loud reaction from a lot of people in the public. What did you hear from people who get health care through Kaiser Permanente?
Essentially, our members wanted to know, were we going to change either our benefit or our care? And the answer to that is twofold. We are not going to change the benefits. We have a long history of removing all kinds of cost share from prevention services, so that will remain in place. No cost share. We highly encourage women to come for mammography. What may change is more information actually to that member that's informed by the recommendations of the Prevention Task Force.
Now, Kaiser Permanente is what's called a staff model, a plan where most of your providers are on staff, they're getting paid a salary, as opposed to a lot of other insurance coverage where an insurance company is paying a doctor or another healthcare provider for specific services and paying them more the more they do. How does that difference in model affect how you perhaps respond or incorporate these sorts of recommendations?
As you've indicated, our physicians are not incented by volume. They're incented to take care of the population and achieve health outcomes. And I think this might be a very good question also to have Dr. Siltebo respond to, who's worked in this system as a physician for many years and can talk from the clinician side.
As a practicing family practitioner, my view always was to care for the patient, to apply the best knowledge that I had to communicate with the patient. And the joy of my practice was that I didn't have to take into account that monetary component for that individual patient. I didn't gain by recommending something. I could make a decision based on what I thought was the best recommendation, and then taking into account what the patient was going through and what their thoughts were. So it is a type of practice that I can't imagine doing anything different, and did it for 25 years.
Okay, thank you very much, Sue Hennessy and Dr. Tom Siltebo from Kaiser Permanente Northwest.